thanks very much to both of you, and I share your optimism that we can do better and we have to do better. I'm nervous that some of the potential solutions that we're tossing around could be at least partially myths. And to give three of the potential myths that make me most nervous, you hear people say that better quality can save money and we can pay for healthcare that way. Another potential solution that individuals behaving as consumers can make the healthcare system work. And then the potential solution that IT can solve all of our problems and save money and lead to major reductions in cost. Do you think these potential solutions, if any of them might be overrated, and if they are, what are the implications for the two candidates' positions?
There are about 6 or 7 ways people have thought of that would rationalize, modernize healthcare. And we don't have great evidence on which of them will work. And in fact, I think thinking of them individually is the wrong way to do it. That is, you could pay for a computer for every doctor and you'd have a very heavy paperweight. You could give a doctor a performance incentive, and if she has no information, she can't do any better. So you're going to have to it's going to have to be the whole system together. What Senator Obama said is the cost problem is so severe that we'd better try everything we can think of. And some will work to save money and some will not work to save money, but we have to try everything we can think of. The only thing he's not in favor of, that's an idea that a lot of people are in favor of, is making individuals pay a lot of the cost on their own. And it's exactly because of the issue you raised about our consumers being, are individuals really ready to be good consumers. But everything else, he said, we need to try, and we need to try it as much as we can, as rapidly as we can. Now, to me, the right analogy is not the kind of big bang savings, but it's what's gone on in manufacturing in the US for the past 30 years or so. Every single year, manufacturing productivity increases by about 2% or so. Manufacturing output per worker increases by about 2%. That's the source of real gains in living standards over time. It's why prices of manufactured goods go down. And the reason is not because firms do any single thing, not because they bought a computer, but because that's what the focus is. The focus is on how do you deliver a better product cheaper. And that involves getting the right information, getting the right incentives, and getting the right framework in which that happens. And so I see this as creating the framework in which all of this can happen, investing in the information, getting the incentives right, getting the goals right, so that that's what we're focused on, is delivering a better product. Whether that turns out to be a myth, if it turns out to be a myth, the only thing we have left in our tool bag is to ration access to care, if we really care that much about cost. Everything else is in this set of proposals. And it may be that will fail, and that what will come to is an explicit set of rationing of care. But what Senator Obama wanted to do is try every single thing short of that.
Quality can save money, but quality in and itself doesn't necessarily save money. It depends a lot on the structure and the incentives that go on with it. Health IT is a means. I agree with the notion you have a heavy paperweight. Interesting CBO report that recently came out indicating that people are way too optimistic in terms of looking at health IT. It will take a while to be implemented, introduced and implemented, and access. It's one of the reasons I think we need to tamper the notion of how quickly we're likely to actually achieve some of these savings. I think individuals can participate in some of this decision making. They need to have information about prices and quality. They certainly can't do anything if they also don't know something about comparative clinical effectiveness, the quality of the institutions and the physicians they see, the prices that they are going to face. Senator McCain is not trying to push everybody into high deductible plans. Most high deductible plans do exempt prevention, or at least those areas of prevention that appear to be cost effective. But for people who don't want to do that, that's certainly not an issue. So I think we need to be realistic, not about the importance of trying to improve the delivery system, but to recognize that this is going to require some time to happen and some time to see the effects of that, either in terms of improved quality and outcomes and to slow down spending, and to not have expectations that, to me, are simply unreasonable and unrealistic. We can't do everything at once, but we have to pick and choose areas that we think are going to be most important and start there and put a lot of effort, and then sequence the other changes as quickly as we can. The good news is that there is a lot of agreement, even during campaign season, about the kind of delivery changes that need to occur in our system.
Both of you stressed the urgency of the problem. David said the cost problem is severe. Gail, I think in your earlier remarks, you said it's the most critical issue is to slow growth. So we're at $2 trillion in health spending now. By 2017, we'll be over $4 trillion. Under your candidate's administration, how much would they bend the curve? How would they do that? And most importantly, how would they deal with the interests that would lose money since someone's spending is someone else's income?
So I can't answer specifically the estimate of over the course of a decade how much they will be able to bend the curve. So let me try to indicate more generally how it is viewed that these changes will occur. You definitely have correctly assessed that slowing down spending by the variety of mechanisms of emphasizing chronic disease and prevention, changing how we pay for chronic disease and prevention, specifically going after smoking cessation. I assume obesity, but there's been more emphasis, at least in print, in terms of smoking cessation. Trying to have, this is at a much smaller level, increase the use of generics in terms of drugs, looking at reimportation if that can be done safely. So there are big items, there are little items, making better information available. The real question is, how do you try to put enough in place early, first 2 or 3 years, that over the course of a decade you really can bend the curve? And part of this is to be able to bring patients as consumers and families as potential patients into the mix rather than only looking at the delivery system. And I think that's probably one of the biggest differences.
Let me start off with where I think the academic landscape is, which is that about 40 to 50% of medical spending is not doing any good. Relative to that, what we have said is we believe our plan can save 8% of medical spending. And people say that's overly optimistic. And you just sort of look at the disconnect between how much is there, you take all the ideas that are on the table and you do them, and you say 8%. If you're willing to use the Bush tax cuts as one source of revenue and you're willing to take a lot of the savings that you'd be able to get from covering people, you need 4% of savings to be able to afford to cover everybody. Yes, it's a hard process, but relative to the scale of what people believe, it is manageable.
I just don't accept that number because I don't think we understand now how much is waste. Now, I will say I have a bias. Somebody says waste, it means zero value or harm. So it's zero and negative. If you mean things that we do in the United States that we have a lot of uncertainty, have a low probability of success, don't give much clinical value relative to the cost, I don't believe 40 or 50%. I don't even buy the 30% number, to tell you the truth. But I don't believe we know. I think there clearly are things we do that have zero value. We need a lot more effort to figure out where they are and for whom and what to do about it. But this notion of do we think, and can we likely know before the fact about whether they're zero value, or do we only know it after they're done and they don't have zero value? We're not going to, the two of us certainly aren't going to resolve this.